to stand shoulder to shoulder in them in this symposium. So very thankful for that. The topic that I was given for this talk is radiology for maxillofacial trauma, in which it will be my best effort to tell you about what are the evidence-based guidelines for prescribing different X-rays. Now, हमारे बड़े अच्छे टीचर हैं, नाम मैं उनका नहीं लूँगा, but वो जब भी मिलते हैं तो सलाम के बाद अक्सर पूछते हैं सगड़े वडिश्ता. So हम बड़े कंफ्यूज हो रहे हैं, हमसे क्यों पूछ रहे हैं कि भाई सगड़े वडिश्ता है निश्ता. But I feel from personal experience जब भी हम एक्सरेज ऑर्डर करते हैं तो या सुपरवाइजर TMO को दे देता है एक्सरे, TMO हम गड़बड़शी. And the reason is कि number one I feel that either we don't know what X-rays to order, and number two, you don't know how to interpret those X-rays properly. So, trying to teach you interpretation of X-rays in 20 minutes is an impossible task. So I just wanted to get that disclaimer out first. But I'll try to do my level best to tell you what are the evidence-based guidelines for prescribing different X-rays. So let's start from the basics. Whenever you have a patient presenting to you with maxillofacial trauma, the basic rule is you need to have 2 X-rays. So it varies by site. For example, if we are talking about the mandible, you need to have at least 2 views at 90 degrees to each other. All right. So in the mandible, that would count as either an OPG, and you can supplement it with a reverse downs view or any PA view for that matter of the mandible. However, the same does not apply for the mid-face. If you are imaging the mid-face, you need to have either a 0-degree view, and you have to supplement it with a 30-degree or a 37-degree occipito-mental projection. All right. So whenever this is asked usually in the exam as a first-line investigation, you are supposed to start from plain X-rays, and with plain X-rays, these are what you have to start from. Now, this is a very interesting table I found in White and Farrow, which is considered to be the Bible of oral and maxillofacial radiology. And what they've basically done is they've compared different X-rays and telling you their diagnostic yield for different areas of the face. So I won't bore you with the whole table. I've sort of grouped it for you. The area in red is all of the mandible. Yellow is the maxilla, blue is the orbit, and green is the sinus. So the interesting thing you'll note is that for high usefulness of the X-ray, just for the mandible, you need at least 2 or 3 views. And that's not even covering the whole mandible. You'll have to supplement it with something which might give you a medium usefulness. So again, you can just imagine that you probably have to do 3 to 4 X-rays just to accurately map one bone of the face. So, all right, you might get a patient who just has a fractured mandible, but what about if you have a case in which you have multiple facial thirds of the face are involved? Like if you have a panfacial case, how many X-rays are you going to do? So here is where basically I feel that plain X-rays inherently fall short. So what to follow? Well, I was preparing this presentation, and when I do radiology-related courses, I was trying to find out guidelines. So there was one document that kept recurring, and I thought that I'll base my presentation on that. So there are 2 documents which I found very useful. The first one is the American College of Radiology appropriateness criteria for the imaging of facial trauma following the primary survey. And second one is again the same criteria, but they have a separate document on orbit, vision, and visual loss. So both of these documents are open access. आप इनको Google कर दें. This is the first hit you're going to get, and you can delve into the guidelines if you want to have some additional information. So they've basically characterized different X-rays, and they've given them an appropriateness rating. So you have something, an X-ray which may be given as usually appropriate, which is considered as the best X-ray. Then you have maybe appropriate, which is second choice. And then there's usually not appropriate, which is an X-ray which you should not be considering for a specific scenario. They've also given a relative radiation level with each X-ray, so you know that even if an X-ray is giving you very high diagnostic yield, you are supposed to balance it by considering the radiation that you're also going to give to the patient. So just, I know you might not be understanding these values, which are given, so I'm just going to give you a rough overview. A dental X-ray that is usually done, that gives you about 0.01 millisieverts of radiation. A chest X-ray gives you about zero point 0.1. A whole body CT scan gives you about 1 millisievert of radiation. And 100 millisieverts is the amount of radiation a dental worker is expected to receive over a period of 5 years. So a radiation worker who is handling radiation equipment, he might receive up to 100 over a period of 5 years. So just to put this in context, I'm sure everybody knows about the Chernobyl accident, which happened quite a few years ago. So in that, radiation workers at the nuclear power plant received over 6,000 millisieverts. Anything above 1,000 will give you radiation sickness, and anything above 10,000 will kill you within weeks. Just to give you a context of the radiation doses. So this guideline has addressed different variants, different clinical scenarios, and we're just going to run by what are the best X-rays for the different regions. So we're going to talk a little bit about frontal bone injury, nasal injury, midface, mandible, and the orbit in the end. So for the frontal bone, the X-ray that is deemed to be the most appropriate is a maxillofacial CT without IV contrast. So this X-ray, according to the 3-volume Fonseca, which I'm sure most of you KMOs are studying, they consider a maxillofacial CT as a region which encompasses the vertex starting from the vertex of the skull all the way down to the hyoid bone, preferably with 0.625 to 1.25 mm slice thickness to give you a very good 3D reconstruction. So that is considered to be the best. Radiography of the skull is considered as usually not appropriate. So what we've said is basically that for frontal bone, CT has replaced radiographs for the initial imaging evaluation of suspected frontal bone injury. Now, you also know that whenever a patient with frontal bone fracture comes to you, know that the frontal bone is the strongest bone of the face. It takes over a 1,000 kilogram force to shatter this bone. So you can well imagine that what's behind the frontal bone? It's the brain. So some intracranial injury will be accompanied in such cases. The guideline has given a rough prevalence of about 30 to 87%. So it is ideal if you can combine CT head with a maxillofacial CT scan. So it's going to not only cover the frontal bone for you, it's also going to give you an idea about any pre-existing intracranial pathology which may or may not have been treated. Now you also know that in any case of maxillofacial trauma, there is about 6 to 13% prevalence of cervical spine injuries. However, cervical spine injury, including them in the area of the scan, there is a separate whole document on it by the HCR criteria, so I won't delve into that. If you're interested, again, it's open access, you can view it at your leisure. Now, this category was probably the most surprising category for me when I studied it, because it wasn't surprising that I found CT maxillofacial on top, but the second most appropriate X-ray here was the ultrasound. Now, I was wondering, what does ultrasound have to do with nasal bone fracture? So we're going to get a bit into that. But radiography of the paranasal sinuses, again, may be appropriate, but let's talk more about that. Ultrasound has actually revealed excessively high, almost 100% sensitivities and specificities for detecting isolated nasal bone fractures, which is something very pertinent, especially if you consider probably nasal fractures occur most probably in your younger population. You don't want to expose them to excessively high amounts of radiation. In fact, in two criteria, ultrasound was even better than CT for detecting non-depressed fractures of the nasal bridge as well as for anterior septal cartilage deviation. Nasal radiographs, according to this guideline, has limited diagnostic value because its accuracy is very widespread. It ranges from 50 to 80%. So this is a very wide range. You might miss a lot of fractures if you just focus simply on plain radiographs. So in this case, CT is again considered to be the best option. Coming to the midface, again, it was not a surprise. All of the chemos who are over here, I'm sure this is a part of your books as well, that for the midface, a CT maxillofacial without contrast is the gold standard of imaging and evaluating such patients. And I was very pleased to see that many cases that Dr. Hanif and others who have shared their cases where almost all of them had a CT scan. So that's very good, and I have thought radiography of the skull is considered to be inappropriate. Now, why is that? For injuries of the midface, CT has replaced radiographs because plain X-rays suffer from a variety of disadvantages. You do not get a proper idea of the osseous contour in this region. You do not get a proper idea about how many fracture pieces there are, where are the fracture lines, how much the fracture is displaced or not. And in fact, in a study in which they compared a bunch of radiologists were given plain X-rays and then they were given a CT scan of the same patient, and they were told to diagnose the fractures. So they missed 12% of the fractures that they were later able to catch on a CT scan. So if I have to sum it up, if you combine a physical examination with a Waters view, a Corwell projection, or a submental vertex view, you can verify the presence of a fracture. But you know, as surgeons, radiology is only half the part. Diagnosing the fracture is only half the job. You have to treat it, obviously. Treatment planning is the next step. Basically, when the patient is under, you have to know how many plates am I going to put in, which incisions am I going to use, which fractures do I have to plate, which fractures do I have to leave alone. So basically, to reduce the element of surprise whenever you open a fracture site, it is always best that you have a 3D imaging modality available, and that is CT scan, and that's not your plain X-rays. However, it's not to disregard plain X-rays completely, but the guideline does recommend that you use plain X-rays in locating foreign bodies, especially metallic ones, because CT scans are prone to beam hardening and metallic artifacts. So that will greatly distort the CT image that you are evaluating. So it's better you use such an artifact is not seen with your plain X-rays. So it's better you use plain X-rays for locating foreign bodies in this region, especially metallic ones. Now, coming to a mandibular injury, again, this is when I was going through this portion of the guideline, I was extremely surprised because I don't remember ever in my training or even post-fellowship that I've ever prescribed a CT scan for a patient with just a mandibular fracture. So, and there were some very good points which I found out. I thought I'll share those with you. Basically, whenever you have a low clinical suspicion of an injury, you have, in plain X-rays, you have two options. Either you have access to an OPG, fine. If you do not have access to an OPG, you're working in a periphery somewhere, so then you can do what is called a mandibular series. Now, mandibular series is basically a series of 4 radiographs in which you have a PA of the mandible, you have the bilateral lateral obliques, and you have a lateral view. So then the question becomes that if both are available to you, which one would you prescribe to a patient? Well, you would be amazed to know that a mandibular series was only 66% accurate in detecting a fracture, whereas an OPG's accuracy ranged from 86 to 92%. So OPG is really the king of mandibular X-rays. So, not to disregard mandibular series completely, there are some pros to it. Number one, you don't need cervical spine clearance in order to do mandibular series, but you do need that for an OPG. A patient does not have to be upright, like you have to do it for an OPG, and the patient does not have to remain still for maybe 5 to 10 seconds, as has to be done in an OPG. So then the real question comes that what is better between an OPG and a CT scan? Well, in condylar fractures, and I'm very pleased that Dr. Mushtaq addressed this already, that in detecting condylar fractures, subcondylar fractures, especially with anterior displacement, OPG was far inferior to CT. So CT is much better in this regard. Another conundrum of the OPG, which I've personally experienced quite a few times, we were treating some symphysis fractures. We thought there's only a linear fracture over here, one plate would do the job, and we'll be out in an hour or something. So when we opened the symphysis, quite a few times it has happened that I've come across multiple fracture lines with displacement. And then I was wondering that I've only ordered one plate, how am I going to fix this fracture? So again, the element of surprise is something that is not working here in your favor. So for symphysis fractures, again, it is better to have a CT scan. What is better in locating dental root fractures? Again, CBCT or CT ने मैदान मारा हुआ है. Easy. And who wins in the emergency setting? Well, obviously, if you're going to do 4 X-rays, how much time it's going to take? You're going to do an OPG, you need cervical spine clearance, it's going to take again time. So in emergency setting, CT is again better. It is quicker, it gives you 3-dimensional views. So, and again, you won't find OPG or a X-ray machine. You will find a CT scan in your emergency departments. Now coming to the last portion, which is about orbital injuries. So for orbit, again, no surprise that you need to have a CT scan without IV contrast. You might have noted that I'm repeatedly using the term without IV contrast. The reason is that even if you give IV contrast, your diagnostic yield from the CT scan does not improve radically. Plus, if whenever you have to give a IV contrast, you have to ensure that the patient's renal function tests are within normal limits. So if a patient has come to you in emergency, somebody just found a person lying on the road with a fracture, you know the patient is unconscious, how are you going to take a history about their pre-existing renal function? So that's why in emergency setting, this is not what needs to be done. So you can do a conventional CT scan, no problem. So radiography of the orbit again is usually not appropriate. MRI and MRA do have a role, especially if you have it's somewhat of a complementary role in discussing or diagnosing optic nerve edema, avulsion, injury, neuropathy of that. So for those cases, an MRI may be done. But first line, you have to go with the CT of the orbit. Basically, the main issues that plague plain radiographs in other scenarios are the same over here. You don't get any idea about the contour of the orbit. You get no idea about the orbit apex. You get no idea about any muscle entrapment, soft tissue herniation. So again, it's more of that you will have to open the area and then you'll have to see what you're dealing with. So in such cases, that's why it's deemed as insufficient. And basically, orbital CT is superior at every aspect of diagnosing orbital trauma. Now, one thing you might have noticed that I really did not take much time to address CBCT. Well, CBCT came quite late to the party, and so recently I came across some research on the topic. So a few papers that I came across, they did recommend that if you do not have access to a CT machine, or if the patient is not affording for some reason, then a CBCT can somewhat play the role of CT, and you don't need to do a medical grade CT for such patients. For most dental hospitals, I'm not aware, but wherever I've worked, we used to have issues with sending patients to radiology because they used to have a fixed quota of patients that they used to do, and patient affordability was an option. So we used to have access to a CBCT machine at our hospitals. We just used to send the patient right next door and get a CBCT done within no time, within an hour, and we used to have all the information that we needed on that. So this is a table that I found in an article which I thought perfectly encapsulates what I'm trying to convey over here. It's published in 2009 in Dental Traumatology. So you can see they're comparing different radiological modalities, and you can quite clearly see that CT is the best. It gives you 3D images, gives you hard and soft tissue differentiation. Its disadvantage is it may not be available everywhere. It has the highest radiation exposure, and the cost is also very pertinent considering the fact that we do live in a third world country. CBCT again is giving you relatively the same advantages, but other than the lack of soft tissue differentiation, it has lesser radiation dose than CT and is less prone to metallic artifacts that are commonly seen in your medical CT. So what are the latest advancements? The funny thing is the article I found for latest advancements is of 2005 and we are living in 2023. So these conditions these advancements that you see, most of them have made it into regular practice in the developed world. In fact, even systematic reviews have come out on them in the last 3 to 4 years. If you focus on slide F and H, this is usually the 3D reconstruction that you see whenever you order a 3D CT scan. But as you can see, it's a bit difficult to tell what structures are here. So they've developed a new lighting technology in which now, instead of volumetric rendering, we use something called cinematic rendering. So slides E and G, these are basically cinematic rendering or cinematically constructed 3D views. So you can see quite clearly what the fracture patterns are, how much displacement is there, and the review thought that this modality is much better at explaining fractures to a patient whenever you're taking the time to discuss treatment options with them. Real-time ultrasound and basically real-time ultrasound and merging of MRI with image guidance. So this is basically dynamic navigation. So it has found its place. A couple of reviews came out in 2018, even one in 2021. So they were of the opinion that for orbital surgeries and mid-facial trauma, navigation has greatly improved the outcomes that they see when operating on such patients. Now, I know I said in the beginning that teaching you interpretation in 20 minutes is not really possible. However, what I can do is recommend books for you, especially the PGs over here, that what you need to study in order to be proficient at interpreting X-rays. The books that I would recommend are Essentials of Dental Radiology and Radiography by Eric Waits. CT is almost an essential part of your IMM and Part 2 exam. For that, I would recommend the CT Teaching Manual by Matthias Hopper. And whenever you want to learn something, it's always best to have a good atlas at hand. So a pocket atlas of sectional anatomy by T.R. Muller is also a very good book, gives you the anatomy for both CT scans and MRI. Now, before I sign off, like I said, this is my first time as a speaker at a national level symposium. I thought this would be an opportune moment to acknowledge a few people, and I think I'm well short of my time limit, sir. I hope it's okay. So, the first couple of people I want to acknowledge are my radiology saviors. This is Dr. Adnan Khan and Dr. Sadia Gul. Both are FCPS and Fellows of the Royal College of Radiology, certified radiologists, and these are the two people whose brains I've picked relentlessly in order to be somewhat apt at radiology. And more importantly than that, they are probably the best brother-in-law and sister-in-law one could ever ask for. In addition to that, I'm extremely indebted to my undergraduate and postgraduate teaching faculty at both PCB and Sadar Begum College, particularly Sir Jawad Kundi, who not only let me come to the symposium, but also helped me greatly in preparing this presentation document. However, the people I would like to acknowledge, maybe second most, are my students at final year, house job level, and especially my TMO, some of them who are sitting here. जो लर्निंग आप लोगों के क्वेश्चंस, आप लोगों की क्यूरियोसिटी, आप लोगों की इनोवेशन, योर फ्रेशनेस, योर विगर से होती है, I think that level of learning does not happen anywhere else. So my message to all of you would always be to always be curious, always be inquisitive, because real development, real change in the community actually comes from your curiosity. So never lose that, and probably this is the reason I am standing here, is because of the curiosity of you people. Lastly, the person I would like to acknowledge is the person sitting on my left. Most of you might know him as a strict, disciplinarian, tough but fair administrator. But underneath all that is yet a simple, loving, caring, extremely generous and loyal human being. Who passed on the love for maxillofacial surgery to me, not only through his genes, but also the way that he carried himself. So that's something I try to imitate, and maybe my son one day might do the same. So thank you very much. Just wanted to say